This is BoomerLife on CL 650.
Don't sleep in the subway, darling. Don't stand in the pouring rain.
Hey, and welcome back to the show on CL 650. We're talking with Dr. Charnel Muir, the SnoreDentist. And the whole idea of this show is if you sleep better, you will live better. And a lot of people snore, and it's a problem with noise, but it can also be a sign that you have some form of sleep apnea, and that's why you need to get tested. And Dr. Muir sends you home with a home sleep test. Now, this is different than going to a sleep lab.
Right. So this is a kind of a cut-down version of that. So the sleep labs in our hospitals, they have more monitoring leads on them. Mm-hmm. So they'll monitor brain waves, leg movement, eye movement, all sorts of different things that they're looking at.
Now, I said I had a hard time falling asleep with your home sleep test. I can't imagine in a lab that people, like they've got all these probes on them, falling asleep must be tough.
It can, certainly for someone who has insomnia, falling asleep in a sleep lab can be difficult. I actually had a patient in not too long ago, and she said the technician told her she was the shortest sleeper they'd ever had in the sleep lab, and she had 2 hours and 9 minutes the whole night. That's all they were able to record.
Wow.
She couldn't sleep the rest of the time. But, you know, and that's one of the limits of the home sleep test is that if patients stay awake through the night, we don't get a lot of data on them. And because it's not measuring brain waves, we have to take the person's word for the fact that when they slept or when they were awake. So there's a small diary that we ask the patients to complete in the morning.
Well, anybody that's wide awake in the middle of the night, they just look at the clock. So they can probably pretty accurately tell you when they woke up and went to sleep.
Yes. Now, if they truly are an insomniac on a chronic basis, they know they're not supposed to have a clock in their room. Yeah. So you don't want to focus on it because you get this whole, you open one eye and you go, okay, if I fall asleep now, I'll get 4 hours. And then you close your eye. And then you open your eye again and say, if I fall asleep now, I'll get 3 hours and 45 minutes.
Yeah. Well, I have a colleague of mine who only sleeps about 4 hours a day.
Yeah. And some people are short sleepers. They really are.
And he reads dozens of books a month because he can't sleep.
Yeah.
And so I was on the plane talking with him, sitting next to me, and I was talking to him about this, and I said, "Are you tired all the time?" He goes, No. I said, "Oh, I'm the king of the nap. Like I like a good nap." And the guy behind me in the seat behind me says, "Hey, it's not a nap. It's called man rest." So you can work that into your practice.
That's right.
How often do you get man rest?
Man rest. That's funny. No, it's true, though. Some people are short sleepers, and it's not the standard by any means. We normally recommend people get 7 to 9 hours of sleep every night, ideally at one go at it, but naps certainly are acceptable as long as they're limited.
Mm-hmm. Now, as someone like myself who likes some man rest, is that a sign that you have some sort of sleep apnea? It's just been a sort of a part of my life that often in the afternoon I'll have a 15-minute nap just because I feel so much better when I wake up and can push through the rest of the day.
Well, what it's telling you is that you need more sleep, or you've gotten into the habit of waking early and then having a nap later in the day. And as long as the nap doesn't disrupt a normal, good sleep cycle at night, then it's usually fine, according to most of the sleep physicians that I've talked to. But, it's telling you that you need the sleep.
Okay, now let's get back into my home sleep test, and we found out that I snore through the night. I snore on average 13 hours.
13 times a minute.
13 times per minute. And now we're getting into the apnea part of it, if it's found any sort of obstruction there.
Right. So, and it did find it, but majority, and classically so, on your back.
Right.
Right. So, and you already had kind of implied that you knew that you were worse on your back for the snoring. So it isn't surprising to us that the sleep apnea that we did find, which is only in the mild category overall, but is worse on the back, right? So we would expect that. Now, interestingly, you've been trained well, and even with the monitor on, you only spent 27% of your night on your back.
Well, I can't fall asleep on my back.
Right.
I have to fall asleep on my side, and then I roll on my back, I guess, sometime during the night.
Right.
I can often wake up on my back.
Right.
Yeah.
And that may be that your body's waking you up.
Right.
It may be that that's when you're more at risk. You're having those sleep apnea events in that position. So your body's waking you up and saying, no,
Lie on
roll
your side,
over,
yeah.
right? Most people, even if they avoid back sleeping, they'll spend some time on their back, even if it's going from side to side. There'll be a transition period. The biggest problem for a number of patients will be shoulder and hip pain when they are side sleeping. So a lot of our population now have had previous shoulder injuries, have maybe deterioration in their hips, or have leg pain, and so they are more comfortable on their back because of the shoulder hip pain. Other patients have back pain, can't sleep on their back, and have to sleep towards a side. So it just depends on what the patient brings to the table for other discomforts as to their favorite sleeping position.
So I have mild sleep apnea.
So overall, mild apnea, kind of right in the middle of that category. So mild sleep apnea means that patients will stop breathing anytime from 5 to 15 times an hour. And you're right in the middle at 9.8. So right in that mild category, right?
So let's go through this. 9, I stop breathing 9 times an hour.
Yes.
Okay. So that's like every 6 minutes or 7 minutes, right?
Right. And for some people, they're like, oh, that's horrible. And to us, we're like, yeah, great, you're only mild. But one of the things...
So what's the worst you've seen?
The highest index I've ever seen was 108 times an hour.
Wow.
Yes.
So I'm at 9.
Yeah.
I got a ways to go.
Yeah. So it's good
This
news.
isn't where you want to be first.
No.
Yeah.
This is not where you want to be the high number, right?
Yeah.
This isn't the card game where you want the ace. So it just depends on where that patient is. Now, you'll note that the categories are pretty broad, right?
Yeah.
So mild is 5 to 15. Moderate's 15 to 30. Severe is anything over 30, because we really don't have an endpoint for that. Patients still surprise us at the number they can come up with on the severe scale. But those criteria and those categories were originally developed when we were first looking at sleep apnea, and we really actually didn't know what the categories should be. But
you didn't know where to set the parameters.
We didn't know, but they're quite broad for a number of reasons. One is there will be night-to-night variability in any one patient. We could do this test again, and instead of 9.8, it might be 7.2, or it might be 11.1. So there'll be night-to-night. If we did it with your cold, for instance.
It might be much worse. Yeah.
Right. So it'll have night-to-night variability. It'll have to do with whether you have a cold, whether you had a late night meal, whether you've had any alcohol, the sleeping bed, pillow, position, what time you went to bed. Any number of those things can affect this number. But it gives us a category. So we're in the mild category versus moderate category versus severe.
Do I have any obstruction of breathing on my side? Is it just on my back?
So what we do is we found that there is very mild on your side, just creeping into the start. So on your side, it was 5.
Okay.
So 5 to 15 is that mild category.
So this is something you typically see gets worse as you get older.
That's right.
So that 9 to 15, say, on my back might end up being on my side.
That's right.
I see. Okay.
Yeah. So on your side, you can control the vast majority of the apnea events and just have some snoring events on occasion, and that may or may not be disruptive. When you're on your back, that's when we see the snoring and the sleep apnea increase. And we also noticed on the types of events where you were having them is that when you were having the apnea type events was when the oxygen was being affected.
So that's why you have the finger probe, because
That's
it
right.
shows the stopping of breathing followed by a drop on oxygen.
That's right. So your oxygen dropping down was 10 times an hour.
Okay.
So pretty well correlates well with your 9.8 events.
And how much?
How much does it drop down? So you have a baseline. When you first put the monitor on and you were awake,
Sure.
you had 94% blood oxygen. So
Is that pretty good?
94% of your red blood cells running around had oxygen. We like to see 94 to 98.
Okay.
Right? So that's
I'm
what
on the
we're
low
looking
end.
for. But it could have been that finger.
Right, I see.
It could have been where it was placed on
I
your
see,
finger,
okay.
anything like that. Now, it did drop down to 85.
That's quite a big drop.
Right. So there was enough of an airflow restriction that the oxygen was deprived down to 85%. And it was below 90% for 6% of the night. So over the entire night, you spent 6% of it at what we consider lower than ideal oxygen, which is below 90. Because you can imagine when you go to sleep, you don't need your awake oxygen rate. You're not
Right.
using your muscles, you're not
Yeah.
moving around, you're not doing all these things. You can survive at a lower oxygen rate in sleep. But we like to see it 90 or above. And we spent 6% below 90.
And you're
okay?
saying that 6% typically will go up as you get older.
Right. So
It's not going to improve.
Right. So one of the things that we really notice with younger patients is that they don't what's called desaturate as much as older patients. So often the oxygen desaturation, or the number of times the oxygen goes down, doesn't correlate in a much younger patient than a much older patient. So we look at both the sleep apnea index and the oxygen desaturation index. And there's quite a debate in the industry right now which number we really should be focusing on. Is it the oxygen that's really causing some of the main issues? Is it this apnea, fight and flight that's really causing
So
the
that's the
issues? Or is it the
adrenaline-
combination?
Right, because your body starts itself like, what's the word I'm looking for? Startles itself awake,
Right.
yeah.
Yeah. So you get that adrenaline rush, high blood pressure, increased heart rate, all those, the fight and flight, right? So your brain unconsciously in sleep thinks the enemy is choking you. It wants to fight back, right? So, and the other thing of note is that of the events that you had, they were in clusters. So they probably are related to a stage of sleep when you go into the deeper sleep, right? Or a REM sleep period. Whereas in other times, there weren't any of the air restriction events. So, you know, we can see that on the study. It's quite classic. We often will see
From what
that.
I understand, sleep cycles are about 90 minutes, right?
That's right.
So do they correlate to be 90 minutes long?
Yours are slightly shorter than that, and it could be because of your travel.
Right.
It could be that your actual circadian rhythm of sleep can be disrupted by your constant travel and different time zones.
Yeah. So I don't even know where I am when
That's
I wake.
right.
Sometimes I wake up in the hotel room and I'm like, where am I? We're speaking with Dr. Charnel Muir, the SnoreDentist, and the correlation between snoring, sleep apnea, and after the break, we're going to get into what are my next steps. What is going to happen next? Once I found out, I know I snore. I found out I have mild sleep apnea. What's next? Dum bum bum. With Dr. Charnel Muir on CL 650.
Celebrating the baby boomer lifestyle. This is Boomer Life on CL 650.